Darracott, I'm just going to ask you some questions. This is going to be a slightly different interview in that I was always very struck back in the 60s where they had this famous series of interviews between a chap called John Freeman and people like Evelyn Waugh and General Montgomery and people like that, where he really did great questioning with them, and it became a sort of a signature thing that people still remember 45 years later. So it's I want to get some personal questions in and just to get your feelings on things as well as everything else, if that's all right.
Sure.
Okay, so what I'd just like to start off with is your background. I mean, you're from Virginia, and just tell us about your early life there and what it was like in high school and the rest.
Sure. Well, I grew up in a medical family. My father was first a general practitioner and then went to New York when I was in the first and second grade and specialized in otorhinolaryngology. And his brother was a general practitioner in a little town called Ashland, Virginia. So I grew up in a very small town, and then we moved to Richmond when I was in Virginia when I was in the sixth grade. And I was there through high school, so I was oriented towards medicine from the beginning. But I had a nice rural beginning of my life.
Did you ever consider anything else other than medicine, or was it always that?
Always that.
And then you went off to university.
I went off to Washington at Lee University. My parents wouldn't let me apply to University of Virginia. They thought it was too liberal. And Washington Lee was a small school, but very good science mixed with very good liberal arts. And I'm a great believer in the importance of liberal arts for someone who becomes a physician, because it broadens you greatly. And I had a great experience. I was not a stellar student, but did well enough to make it into medical school, and my major mentor there was my organic chemistry professor, who the third year basically said, I want you in a desk outside of my office 4 days a week. You can party all you want on the weekend, but he's the one that really brought up my grades and helped me get into University of Virginia, where I went to medical school.
Great. So when you went there, was it always urology, or were you going to be something else at any stage?
Well, this is fascinating. When I was a college student, my father got me a job as a scrub nurse at a hospital in Richmond. And one of the things that really impressed me was Dr. Austin Dodson, D-O-D-S-O-N, Dr. Dodson's group of urologists who were so precise in their diagnosis. They'd look at an x-ray, see a little white dot, make a little tiny incision, ask for Babcock, and pull out a stone. The general surgeons would do exploratory laparotomies and root around the abdomen for a while, not find anything. So I actually read Austin Dodson's textbook on urology before I went to medical school. So I actually was oriented towards urology, period. And then in a preliminary course, Dr. Al Paquin, P-A-Q-U-I-N, who's well known for his work on understanding the trigone, and developed one of the first reimplant operations, the Paquin procedure, introduced me to some of the embryology and some of the science in urology. So I was hooked very, very in urology very early in medical school.
And in fact, your work centered on things like the adrenal as time went by, and then you diversified. But that was there any reason why that was the first port of call for you?
Actually, that's another interesting story. The big change, I took my surgery at Vanderbilt. I was planning on going back in private practice with one of the urologists in Charlottesville, but when I went back to Virginia, unfortunately, Dr. Paquin had died, and there was a young chap there named Jay Gillenwater, and we began our work on obstruction, and I suddenly realized that I really enjoyed the laboratory, and that was a huge shift. I had assiduously avoided the laboratory during medical school. The work began with obstructive uropathy, as you well know, but I was intrigued by the activation of the renin-angiotensin system during that work, and therefore decided to take a fellowship in that area. And it was the work with John Lara, who was L-A-R-A-G-H, John Lara, who was brilliant and should get the Nobel Prize, but I don't think he will, who not only tweaked my interest in renal vascular hypertension, but also the adrenal and primary hyperaldosteronism. I also worked with Dr. William Scott at Vanderbilt and Bob Ramey, and Dr. Scott had written one of the key textbooks on the adrenal. So I was exposed to the surgical aspects, but I really got involved in the adrenal because of adrenal physiology, which is quite different from the way most people get interested in urology and the adrenal.
So let me just ask you, you have dedicated a lot of your life to academic pursuits, and you mentioned about your very well-known work in ureteric obstruction, and you've stimulated a lot of people to do academic research. In many cases nowadays, this whole academic research issue, particularly in our part of the world, is becoming less used by people. How would you persuade people that it's really got something for them?
Well, I think the step one is we have added back, Dr. Peter Schlegel has added back a research year in training. If you never see research, it's very difficult for someone to start de novo at a later time in their career, particularly when they're ready to go out and practice and finish residency. So I think step one is hopefully exposing medical students and residents to a research experience. The second thing is, and the most important thing to engender in these wonderful residents that we have, is a sense of curiosity. What would they like to learn? What would they like to add to the body of knowledge? Pat Wallace put it nicely one day talking to me, and he said to ask the resident, what gives you tachycardia? Because I think that you can't force research on people. They have to become very interested in solving a problem, and then the third step is, of course, once they finish residency, is to have funding for them to take a fellowship, and then certainly funding as a junior faculty. It's very difficult these days. In this country, we call them RVUs. The dean and everyone wants everyone to bring in a lot of money, but you've got to protect the people to do research. But I think the main thing is trying to ignite a flame of just fascination or passion for solving a problem. And I still, thoroughly enjoy looking at a clinical problem, and even if I'm not doing the research, wondering how would you approach this? How could you attack it? What model could you set up? The final comment is that at the present time, and even when I was coming through, as clinicians, we will spend a good bit of time in our clinical work, so we have to work closely with our PhD colleagues.
Well, let me just push you a little bit on that, because at what stage do you think you would like to try and start stimulating the people into solving a problem? Is it during their residency year, or as medical students, or when do you hope to catch them?
Well, I think one of the nicest things that's happening in medical schools is that they're beginning to do problem-solving cases, at least at Cornell, as first-year students. So they'll give them let's just say a case of primary hyperaldosteronism, and they'll integrate the basic science, the clinical aspects, and then if the teachers are really good, they will begin to bring in some of the unknown quantities, not just what is known. So I think hopefully this is beginning in medical school, but I think it's critical that you do it during residency. It's unlikely in my mind that a resident will, certainly a resident will go off and take a fellowship in robotic surgery or laparoscopic surgery, but that's for clinical reasons. It's unlikely that they're going to go off and work with someone to understand the basic biology of bladder physiology if they haven't had some stimulation in residency. So early as possible.
Thank you, Darracott. Now, so you obviously we have Richmond, here we have Nashville, and then New York. So obviously a big change, but it seems to me, and obviously I've seen you in your castle there. You adapted very well. In fact, I think we could say that you enjoyed life in New York City very much. Is that correct?
Well, I think that the fascinating thing to me was I went with John Lara at Columbia, and it was a whole new world. There were 5 of us in the lab, 2 Americans, 2 Swiss, and 1 Greek. The whole atmosphere was dedicated to the laboratory, advancing science, presenting at the major internal medicine meetings. It was intense. It was incredibly competitive, incredibly intense, and incredibly exciting. And actually, when I went back to Virginia after that, Ann and I both said that if the opportunity ever came, we would love to move back into the city. So the challenge to move to a department that was incredibly well known, that's Victor Marshall's, who was a giant in urology, to move to his department was an incredibly challenging but exciting opportunity for me. So we had enjoyed the pace of the city, I enjoyed the challenge of the city, and so it was exciting to move up there, even though I was pretty young at that point.
Well, just moving along, you referred to Victor Marshall as being a giant of urology, but I hope you don't mind my saying that I look on you as being a giant of urology, and it's on that you've had a huge number of honors and awards. The one thing that I'd like to ask you about that perhaps the readers might be interested in is your presidency of the AUA. I know you're going to be president of the GU Surgeons in a little while, but the AUA obviously is such a hugely important institution in all our lives. Tell me how that was, and what did it mean to you? Give us a personal view about it.
Sure. Well, first, it was a great honor. The path to the presidency of the AUA comes through what we call the sections. So I had been president of their section, and so it was an honor that my section then chose me to represent the section as president of the AUA. It's a terrific organization, and it has evolved beautifully from simply being an educational tool of an annual meeting to have what I think is one of the best Office of Educations. It's moved into the socioeconomics of medicine as we've needed. It has added office management. When I was president, 2 things that I was very pleased with. Well, one is we had developed an affiliation agreement with the Society for Basic Science Research, which has grown immensely and is incredibly important. And we formed an affiliation with the American Association of Clinical Urology, which has markedly increased our political clout and the number of people that can be involved in Washington, which fortunately and unfortunately is now part of our lives. The other thing that was, of course, terrific is you toured all the different sections in a number of national meetings, such as BAUS and the EAU, and getting to know urologists around the world is just one of the real pleasures of academic medicine, and a particular pleasure being president of the AUA. We have a huge international membership, and just meeting the people and seeing the quality of urology around the world was very gratifying as president. So it was a busy 3 years as president-elect, president, and past president, but just a wonderful responsibility.
Let me just ask you a few questions. First of all, relating to just urology itself, based on your experience, and then I want to just ask you some other little questions about yourself. So let's just find out, first of all, what do you see as the biggest challenge facing urologists today? I guess I can imagine that the U.S. has its own sort of healthcare issues, but either in the U.S. or in the rest of the world, or both.
Well, I think we've already hit on one, and that is I'm worried that we're not advancing the science of urology as well as we should be. And I do think that at our national funding institutions, urology is not recognized as well as it should be, and we need to have more influence politically to obtain more funding for urologic research, because I think that's continues to be the future. I am not as worried about workforce as much as some. I think that we need to use physician extenders. We need to use nurses more efficiently, as well as technicians. And I like the fact that in the United States right now we're fairly lean in the number of urologists per person for population. So I'm not a champion for expanding the numbers in urology very much. The financial problems in medicine are universal. I mean, I don't see the system that is controlling cost, and it's much too broad a topic to get into here. The good news, I think, despite everything that we read in the paper, is the medical students and the residents are just wonderful. I mean, they're bright, they're excited, they're enthusiastic about being physicians, and they seem to never read the newspaper to get worried about what's going to happen to their lives as far as care is concerned. As far as technology, other people infringing upon our field, I'm not worried about that. I gave the Guterres lecture years ago, and the title was Excellence in Innovation, and we've always been able to move very rapidly as technology changes. A good example would be in stone disease with all the newer techniques. So I think we will continue to be innovative, and so I don't worry about our domain shrinking. So I would, I'm a research-oriented individual, and I would put that on top on concerns.
Well, that's very interesting to hear you say all of these, and I mean, one of the things that you and I, indeed, and others have been interested in is, of course, laboratory research. But coming out of all of other types of research are the new technologies. But if you could just give me an idea of what you think, not necessarily technological, but perhaps what has been your view of what is the biggest advancement in urology in the past decade?
I think it would have to be if I showed you a picture of one of our incisions for a large adrenal tumor going from the xiphoid to the pubis, to think that now this is done laparoscopically through 3 little dots. I would have to say that from a surgical point of view, it has to be the minimally invasive surgery in all aspects of that. I mean, if you think of the dramatic changes and the changes that are still continuing with robotics and will continue, so that from a technical point of view, certainly it's hard to pin down something for a other advances, but I would have to put PSA up there. I still don't understand the controversy about PSA. The death rate in this country from prostate cancer is down about close to 30%, and as you know, in George Barch's study, it was down over 50% in Tyrol. And we're going to learn, who needs radical treatment and who can be watched, and that'll happen in the future. But certainly, the diagnostics. I mean, look at the markers for testis cancer. We need markers for other tumors. We don't have one for very good for. We don't have anything for kidney and bladder, but the development of new markers is going to be critical. And then, of course, all the advances that used to be chemotherapy but now include monoclonal antibodies and nanotechnology. It's going to change the whole field. I'm more skeptical about all the money we're putting into genetic profiling. I think we're finding that, unfortunately, most of the diseases we are involved with are not going to be caused by some single gene mutation or some particular one entity. And I think we've done much better, say, with some of the drugs developed as monoclonal antibodies than we have with all the emphasis that was placed on gene therapy. I'm not sure gene therapy has cured anybody at this point. So that's too broad, but it's hard to...
That's perfect, Darracott. Now, you had, obviously, one of your great points is the way you deal with people, and everybody loves speaking to you and getting your opinions on things. Now, I mean, you were, of course, chairman of urology in Cornell, and then vice dean, and so you dealt with a whole range of people. Now, as we're speaking, you're looking out over the prairies in Wyoming. Do you miss interaction with people on a day-to-day level, or is that something that you're happy you put in the past?
No, I think I'd have to say I miss it. I thoroughly enjoy working with people. I always have. One of the other wonders of academic medicine is all the wonderful people you train, or medical students that you influence. We would have about 4 per 100 each year that would go into urology, and they're all over the place at the present time. And I miss the patients. We have terrific patients in urology, and one of the reasons I like urology is we actually cure most of them, and they're incredibly grateful. No, I would have to say I miss that. However, we're in a new community. We will meet our new librarian at a meeting there on Saturday, and we've become active in the church here. And there are 2 historical societies that you would like very much. The head of the Historical Society here at Bighorn at a meeting recently, I happened to take a good look at him. He had his 6-shooter on his hip, as well as his other cowboy outfits. That was an interesting observation. So it's a little different here, but we're meeting new people, and we're going to continue with attending a number of the urological meetings, and we certainly won't give up our good friends like you.
Thank you very much. And tell me, Darracott, the usual questions that one gets asked in interviews like this. What book are you reading at the moment?
Oh, well, it is interesting. I've just finished the Swedish trilogy, and then Cutting for Stone, which is a wonderful book written actually by a doctor, and another book called Half Broke Horses, which is a little bit about the West. So, and a woman who writes a follow-up. She's followed up, named Laura King, on the Sherlock Holmes notion and writes about him and a wife that he has. So it's a potpourri of things at the moment, and also a couple of serious books. But
excellent.
And have more time to read, which is nice. A little more time to think.
Favorite piece of music?
Not really. I enjoy music, but I wouldn't say that I'm not a real scholar in that area.
Right. Now, the other thing too that I want to ask you is, you mentioned several people who influenced your career, but I'd like to know really who your urological hero is, and then following that up with your historical hero.
Okay. I doubt if I can pinpoint it to one, but let me just tell you a couple people and a couple thoughts. Certainly, Jay Gillenwater has to come on top. He changed my life. He showed me the importance of laboratory urology. He did just what we talked about before. He turned on that excitement that led to my academic career. However, during my residency, he had me meet with Bill Boyce at a meeting to talk to Bill. And Bill told me something that I've transferred to many people. We sat and he said, concentrate your research career or your academic career on one or two areas. Don't try to dabble in the entire field. He said, if you take one or two areas, you're likely to even come down with a discovery that might be important in an adjacent field. And I think that was critical. And then John Lara, who obviously that's where my papers on renal vascular hypertension, primary hyperaldosteronism, and understanding of the renin-angiotensin system came out. So those three would have to be on top, and the final would be Dr. Michael Peach, who was a brilliant pharmacologist at Virginia. And the message Monday, there was a fellow from the Cleveland Clinic that had a huge hypertension lab, and we just discovered something that we thought was important. I walk in, and Mike is sharing that with him, and as the guy left, I said, Mike, we haven't published an abstract. We haven't published anything. You just told him what he can go back and do this. He said, Darracott, don't ever forget that we're in this field to share knowledge with other people, and if you don't share knowledge, then you shouldn't be in the field. And I think sometimes we get too insular, trying to protect ourselves. So those are the
they're your main urological heroes. What about your heroes from history?
Heroes from history. That's interesting. I don't know that I've ever really thought about that. I think one of my heroes, because the way he got things accomplished is interesting, is Eisenhower. And obviously he was a brilliant general and quite antithesis of MacArthur. But, he really didn't have any political party when the Republicans co-opted him to become president. If you go back and read the things that happened during his administration, most of which he didn't independently take credit for, a great deal of increase in federal activities happened during his administration, and most people don't realize how much of that happened. I don't know. I could name other people, but probably just stop there.
Well, Darracott, it's always a pity to finish a conversation with you, particularly because I think we're just getting into showing your knowledge and your insight into things, and I'd love to continue talking, but sadly we have to come to an end. And
well, let me leave with two thoughts.
Good.
One, Ann and I will have our 48th anniversary next year. And she has been terrific, as you know. A hint for for young academicians is marry someone who comes from a medical family, because they'll then understand that you have an academic mistress that's going to take a lot of your time. And the second thing is in your accomplishing things, and this is particularly true in my dean's job. I loved it when I could quietly sell ideas to someone else, so when they came to fruition, no one knew it had been my idea in the first place. And secondly, with a big decision, if everyone's a little unhappy, then the decision is probably just about right.